Hi, everyone. Good evening and welcome to the premiere of the first OFA webinar. So what is OFA? OFA stands for Oculo-Facial Aesthetic Academy. And I'm Sabrina Shah Desai. I set up the Oculo-Facial Aesthetic Academy in 2016. And my aim was to teach both non-surgical and eventually surgical aesthetics related to the eye and face. So we are primarily a cadaver-based training academy in London. And we hope to expand to live training once lockdown is finished. So once again, thank you so much for your time and for joining this premiere. Now, we have chosen to run this as a pre-recorded webinar because obviously with live streaming, there are issues with sound, and we noticed that there have been a plethora of webinars, using all sorts of platforms where the sound quality has been particularly poor. And the delegates have not been able to hear what we're talking about. So I've decided to pre-record this bit, and then you just have to post your questions or your comments in the comment box. I will be joining you live in the comment section, in the chat section. And what we aim to do at the end of the webinar is either we can continue chatting in the comment section, or I will plan to do a follow-up video on Saturday, the 9th of May, where I'm doing a follow-up webinar answering all your questions. So without further ado, I'm going to start the seminar, and I'm going to share my screen and start off with the talk. So I'm talking on my favorite topic, which is tear troughs. What is youthful or normal? And I'm always surprised at what is portrayed, or what the patient expectation is, and what they mean when they talk about the tear trough. And we're trying to restore normality in an area, and we've defined this tear trough area as a deformity. But actually, what the patient is seeing and what we're seeing and trying to treat are two different things sometimes. So let's look at what an ideal youthful tear trough looks like. Okay, so this is a shallow concavity. Okay, this lower lid area is a shallow concavity, blending quite seamlessly into a convexity of the cheek. And you really can't see any of the ligamentous or bony anatomical landmarks. And this is really the ideal we're trying to achieve. However, if you look at this child of Indian heritage, you can see that already there is a difference in the anatomy, where there is the visibility of a tear trough ligament, there is some hollowing under the eye, and already what appears to be a constitutional hyperpigmentation. And then if you look at an Afro-Caribbean child, you'll see that often the Afro-Caribbeans can have some maxillary hypoplasia. In fact, children can have maxillary hypoplasia, and they end up with this under eye hollow that extends into the mid cheek area, which is the mid cheek groove. Also, it appears as if they have some swelling here. The malar mound is prominent, and this is a child. So this is a youthful tear trough. And then finally, if we look at one more ethnicity, this is the Chinese girl. And you can see in this Chinese girl, there is an under eye hollow and what appears to be a bit of a bag, but this is really a hypertrophic orbicularis oculi muscle, which is creating this kind of a shadow along with a mild fat bulge. So in fact, the tear trough is, even in youth, exists, and it can be more prominent in certain ethnicities. And so one really needs to understand the ethnic ideal of the population that we're treating, and also the ethnic anatomical differences of the populations that we treat. And certainly if an Indian patient wants to have an under eye that a Caucasian patient has been born with, then this is going to be a recipe for disaster, because their anatomical differences are quite marked. So again, we've got celebrity and media Photoshop filters abound, particularly on social media. And these are sending out messages to people who come to seek these treatments, to go in for this really photoshopped appearance where this under eye hollow doesn't exist. But as you can see, the biggest difference in Kim Kardashian's under eye is actually treating her palpebral malar groove. And this is really what is aging as we get older. Of course, you can see the difference over here, a bit of a bag with a deepening in the palpebral malar groove, with a central part of the groove that goes into the anterior projection of the cheek. So really, that's how the under eye ages. You can see a plethora of celebrities who have gone in and got their under eye treated, the tear trough, and you can see Daryl Hannah with 2 speed bumps, and you can see this visibility of filler, which is lying in the nasojugal groove and is apparent every time a patient smiles. And so one really needs to distinguish that when you finish your treatment in clinic, you may end up, going for an effect where it's a completely eradicated tear trough. But 6 weeks, 8 weeks down the road, you find that this is changing, and the patient ends up with a sausage or a speed bump under the eye. So let's review how the under eye ages. And I'm very aware that my photograph keeps coming in the way my screen, so I'm going to keep moving it. So let's look at how the under eye ages. Okay. And I think so this is a young lady in her late 20s, and already she's showing the signs of aging. The under eye ages with grooves, and it ages with hollows. Now, this is, irrespective of whether you're a man or a woman or whatever your ethnicity. But paradoxically, the under eye also ages with volume excess, and it does age with hyperpigmentation. So let's look at the grooves in more detail. So the first groove that is visible under the eye, and this is visible as I showed you in youth, is the tear trough groove. This is an absolutely normal groove highlighted in green, and this exists because of the presence of the tear trough ligament. Let's look at the next groove that is actually a sign of aging and doesn't generally exist in youth. This is the palpebral malar groove, and this is highlighted in yellow. Now, of course, this is where we need to distinguish what patients are reading, particularly when they surf the net and they're on Real Self or Professor Google telling them that you only need 0.5 mils to treat the tear trough. That is true if we're only treating this area. But if you have to treat the palpebral malar groove, and you have to treat the mid-cheek groove, then you are going to need additional volume, but it's going to be a progressive volume. And this is where the discrepancy comes in, because the patient is expecting, a miracle effacement of the tear trough as they see it, with this 0.5 mils max. But actually what they mean is this entire area as the tear trough. Whereas what we mean when we talk about the tear trough is this inner corner. So it is incumbent on us to educate our patients as to what the real tear trough means and how the volume differences of what we inject will impact them. Let's look at the third groove. The third groove in the under eye area that extends into the cheek is the mid-cheek groove. And this is, for me, the key for when patients come and tell us they look tired. When this tear trough hollow apparently extends into the cheek is when it'll become extremely visible to people, and they look constantly tired because of this dark shadow. The fourth groove is the nasojugal groove. Now, for a long time, it was felt the nasojugal groove and the tear trough groove are one and the same, but actually there is a distinction, and anatomically there's a distinction, and I'll talk about it in a bit. So let's then look at these grooves in detail. So the first groove, or your tear trough groove, is actually your tear trough ligament. This is a true osteocutaneous ligament that runs from the inner corner of the eye, that's the medial canthus, down to either the medial limbus as a bare minimum or the mid-pupillary line. So it's about 2 centimeters to 3 centimeters in a curvy linear manner. Now, as you can see, it is encased within the orbicularis oculi muscle, but this is the palpebral portion, this is the orbital portion, or this is the preceptal portion, this is the orbital portion. Now, let me introduce Stanley to you. Those of you who attend my cadaver labs are well aware of Stanley. So I have actually used some plasticine and I have put in the tear trough ligament here. So you can see it in green, and you can see this ligament is stuck on the bone. So it's actually exactly on the infraorbital rim in front of the lacrimal fossa, okay, and the anterior lacrimal crest. So you can see this is the true tear trough ligament. Now, anatomically, this structure is attaching the skin, the orbicularis oculi muscle, to the bone. And so in this part of the eyelid, which is highlighted here, there is no fat. There's no subcutaneous fat and there's no deep fat pad. So this is what causes the tear trough groove. But actually, this groove uh, is on the bone. But as you can see, the tear trough hollow highlighted in yellow here occurs superolateral to the tear trough ligament. So actually, anatomically, there is something happening to the tissues in this part of the eyelid, which is the preseptal part of the eyelid, which are deflating, which is worsening the appearance of the groove. So it's just that the groove or that tear trough ligament attaches the tissues to the bone, but actually the deflation that is occurring above the tear trough ligament and below the tear trough ligament. And the main deflation is occurring around the palpebral groove. Now, the palpebral groove is caused by the orbicularis retaining ligament, which I'm highlighting here. Now, this doesn't lie on the edge, but this lies sort of, 2 to 5 millimeters at the outer corner below the infraorbital rim. Now, let's look at Stanley again. So you can see that I have drawn the ORL, as it's called, or the orbital retaining ligament in black. And this is, as you can see, a few millimeters away from the infraorbital rim. Now, this ORL is extremely important because it attaches the orbicularis oculi muscle to the orbit. And therefore, it has some nebulous connections, particularly at this part, which allows us, this part laterally and centrally, allows us to put filler here. And this part is extremely forgiving. Whereas when we put filler on the bone in the true tear trough area, this area is not that forgiving, and one has to be very careful with the volumes and the type of product that is injected in the tear trough, because otherwise it will cause a speed bump. Now, if you ever got punched in the eye, you will know that the ORL, this is the surface topography of the ORL. So you can see it goes all the way around the eyelid and it attaches the circumferential muscle, which is the orbicularis oculi muscle, to the bone. So I have actually shown you this orbicularis oculi muscle on Stanley too, and I've actually shown you exactly what it's like. It's a strap-like muscle, but I've shown it in two different colors. So the light pink is the pretarsal and preseptal part, or the palpable part of the orbicularis oculi. Now, this is the part that is actually forms your eyelid. And then you have the orbital part of the orbicularis oculi, which is in darker pink, and it's in darker pink there. And this orbital part of the orbicularis oculi actually lies below the orbital rim. So therefore, you can see that medially, you have, where the palpable orbicularis oculi meets the orbital orbicularis oculi, it meets at the rim, and this forms, is connected with the tear trough ligament to the bone. Let's look at the third groove, and this is the mid-cheek groove. And you can see quite clearly here how it looks as if the tear trough is extending into the mid-cheek groove. But actually, the mid-cheek groove is connected to the nasojugal groove, which I'm going to talk about in a second. So let's look at what forms this mid-cheek groove. Going back to Stanley again, you can see in purple here the zygomatic cutaneous ligament, which the cutaneous adhesions pull the skin down and they form the mid-cheek groove, as you can see. Now, the nasojugal groove is slightly different, and this is where the orbicularis oculi ends medially, and this is where the blood vessels are also contained. So if we go back to Stanley, you can see that where the orbicularis oculi ends, you have, a depression, you have the angular vein, the angular artery. You also actually have the levator labii superioris alicanesi over there, and that forms the nasojugal groove. And as this nasojugal groove deflates, it gets closer to the tear trough because the tear trough is also deflating, and it all seems to amalgamate and extend into the mid-cheek groove clinically. In some people, you can actually see a distinct nasojugal groove, particularly when they squint and the orbicularis oculi muscle contracts. Now let's look at the malar mound. So I'm just going to move my camera again. So when we look at the malar mound, you can see quite clearly here, this is the area, it's already a bit boggy and swollen. And this is the area that is between the orbital or orbicularis retaining ligament, the ORL, and the zygomaticocutaneous ligament. What I want to show you here is, although this has got a fat pad in it, it's got the malar fat pad, the skin quality of this area is different. The skin quality is the same quality of the eyelid skin. So the eyelid skin is thin. It's one of the thinnest skin of the human body. And you can see that this carries on into this area. Whereas suddenly you see these thick pores, the cheek skin is very different. And so you've got a distinct zone of different skins. And you can see that the eyelid skin actually extends almost up to the extent of the orbicularis oculi. And you see this particularly in darker skin types because it's a pigmented skin. So for instance, I always had dark circles that extended up to there, and these often will form a pigment demarcation zone. So you can see the edge of the thin skin because it's a more highly pigmented skin. Right, let's look at the hollows. Now, if you look at the under eye area, and in fact, if you look at the face, I just, look at it as weighing scales, and you start getting an imbalance between the scale. And let's just say, in youth, these scales are equal, the weight, the volume loss equals the volume excess. And so you're in equilibrium, the scales are all fine. But then you have progressive volume loss. Now, in the under eye area, this progressive volume loss is first seen in the skin. So the skin becomes extremely thin and it becomes hyperpigmented. So you will see a sort of sinking, thinning skin, an atrophic skin with fine lines and wrinkles, and you'll also start beginning to see a hyperpigmentation in this hollow. These hyperpigmentations can be different. So if you have constitutional dark circles, like someone of my skin type, you will have a hyperpigmentation there without the hollow. But as the patient gets older, suddenly this skin will start getting excessive. So there is a significant skin volume loss, but that volume loss is presenting itself as excess. So you can see this kind of lax, thin, atrophic skin. And this is where I would say this is moderate skin laxity, whereas this is, just fine lines and wrinkles. So when we look at a Glagau scale, this is what we're looking at to be able to identify what's happening with the skin. The next area of progressive volume loss is subcutaneous tissue. So the area just superolateral to the tear trough, this is a cadaver image, and you can see this is the tear trough ligament, but you can see there's no fat. There's absolutely no fat in this area above or below the muscle. And then you go straight onto the deep fat pad. So when you look at this area, anatomically, at the tear trough ligament, you only have three layers. You have skin, muscle, and bone. You don't really have anything else, and you have the ligament that's connecting everything together. So the true tear trough area is an area where there is subcutaneous tissue loss. But this extends for the entire lower lid because, you don't have any subcutaneous fat over the orbicularis oculi muscle in this entire under eyelid area. And it starts as early as your teens, where you lose this subcutaneous tissue. Then you have a progressive volume loss, which now starts involving the SOOF. So this is the suborbicularis oculi fat pad, or the deep fat pad of the eyelid, and so the midface. And you can look at this SOOF which I've highlighted, here. So this is your medial Trough. This is some methylene dyed filler that I've injected. This is your lateral Trough. This, as you can see, is the area of your tear trough that is hidden between the palpebral and orbital parts of the orbicularis oculi muscle. And this is, of course, all your orbicularis oculi muscle. If we were to look at this in this drawing, you can see that you have your palpebral part of the orbicularis oculi muscle, which is this part. Then you have the orbital part. And of course, you have the tear trough ligament, which is between the palpebral and the orbital part. But then you have the nasojugal groove. And this nasojugal groove is a lower border of the medial orbicularis oculi muscle. So, this area here is your nasojugal groove. You can see this area here, which is the lower border of your orbicularis oculi muscle. And below this orbicularis oculi muscle, you have the orbital septum. Now, this orbital septum is a fibrous sheath that's holding back the intraorbital fat. And then you have, of course, the intraorbital fat, but you also have the Trough. And the intraorbital fat is inside the eye socket. The Trough is lying on the lid margin. So let's look at Stanley, because I've put in these little medial Trough and lateral Trough lying between the ORL and the zygomatico-cutaneous ligament. So you can see that your medial Trough roughly extends from your mid-pupillary line laterally to your lateral canthus, your lateral limbus, and then from your lateral limbus to your lateral canthus is your lateral Trough. So for those of you who don't know what the lateral limbus is, this is the mid-pupillary line. So your mid-pupillary line is where your medial Trough starts, and it will extend up to the lateral canthus. And then from the lateral canthus, laterally upwards is your lateral Trough. Now, let's look at further progressive volume loss, which is now in your deep medial fat pad. Now, this is the fat pad of your cheek. And as you can see on the CT scan image here, the deep medial fat pad is one of the key structural supports, and it extends up to the inferior border of the tear trough. So it's actually like a buttress-like support. It's one of the largest internal pillars that is supporting your tear trough. And if we look at Stanley again, you can see that this is the deep medial fat pad. And I'm going to take the deep medial fat pad out, and you can see the infraorbital foramen here, okay? And I'm going to put back the deep medial fat pad, and you can see how large a fat pad it is. This is one of the key areas that we support. This is the deep lateral cheek fat pad, and this is not that important in restoration of the tear trough. Interestingly, it is the deep medial fat pad, the medial Trough, and the lateral Trough where we actually primarily are injecting deep on the bone to give structural support and to improve the tear trough. So when we inject the deep medial cheek fat pad, we are giving an indirect support to the tear trough, an indirect correction to the tear trough. And when we inject the Trough, we're now treating the palpebral malar groove directly. Let's look at the progressive volume loss. So the progressive volume loss then extends to the orbit and the maxilla. So you can see how the orbit changes shape. It goes from a square to a round. And really, if you're looking at the axis, this is the axis of elongation, right? And then interestingly, there is another change that's occurring, and this is that the SMAS, which envelopes your orbicularis oculi muscle and particularly is present in the septal tissues, is weak inferomedially. Now, what do I mean by inferomedially? I mean, if we look at Stanley again, this part of the SMAS is weak. And this is why the intraorbital fat bulges out at this inner corner quite often. Now, this weakness if in the tissues actually starts presenting itself with an interesting change, which is volume excess. So you now start getting a progressive volume excess that perhaps comes on because of an excess of hollowing or volume loss. And in some patients, you can just have hypertrophic fat pads. So of course, you can see these fat pads really well in up gaze, or you get your patient to tilt down and look up. And this is where you can see the entire extent of your fat pads. And this is a really good clinical way of assessing these fat pads. So if we were to look at the fat pads, you can see this is the medial fat pad, the central fat pad, and the lateral fat pad. So there are 3 fat pads in the lower lid. I'll highlight, you can see the big medial fat pad, the central fat pad, and the lateral fat pad. When we are choosing to treat a tear trough with fillers, the extent of bulging of this orbital fat is extremely important, because when you look at the scientific evidence, people with thin skin and with significant bulging of fat don't do well with tear trough fillers, and you might want to consider alternative treatments, which would include surgical or energy-based device treatments. So the next thing in the progressive volume excess, so we've understood the progressive volume excess is fat, but you also get a progressive volume excess of skin. And then an interesting change starts occurring in the tissues where they start getting boggy, and you get the presence of a malar mound, which can become a festoon. So you can see here, very clearly this demarcation of thin skin. This is eyelid skin, thick cheek skin. There is a boundary zone here where this excess of fluid along with tissue starts occurring. So there is an interesting dynamic. There is volume loss and there is volume excess. So if we were to summarize the hollows of the under eye, you would have the hollows of above the ORL. And you can see this hollow is primarily what we see in Indian patients, Hispanic patients, Middle Eastern patients. When they present to us with dark circles at a young age, you see it in that, it presents itself in the teen years, and it's very early on in up to your mid-30s, where you have this subcutaneous volume loss and thin skin that predominantly affects the area above the infraorbital rim, and you have a hollow area in this preseptal segment of the anatomy. But as one progressively gets older, you start beginning to see a surface topography change. And the topography change is, you see a hill, a valley, a hill, a valley, a hill, and a valley. And so if we were to look at this, this is the septal confluence, which is holding the orbicularis oculi muscle back. This is the fat pad that's bulging. This is, of course, the tear trough ligament and the ORL with volume loss underneath it. This is the zygomatic cutaneous ligament. This is the beginning of a malar mound and the mid-cheek groove. So you can see how the eyelid topography changes, and therefore your treatment algorithm needs to change, and your assessment is extremely important in treating the tear trough. So we're going to take a short ad break. We're not going anywhere, but I would like to plug my training app. This is my virtual reality training app, and you can access it on OFAA.app. There are 23 videos at present where I'm in a cadaver lab, and I'm showing you cadaveric dissections of this anatomy in detail. I'm also injecting hyaluronidase and showing you how to manage vascular complications on cadavers. And you can also join me in clinic to see me doing live injections. And these are not just related to the tear trough. Obviously, these videos involve panfacial rejuvenation and rejuvenating different types of faces, including a male face, chubby face, a slim face, and there's a lot more that will interest you. At the end of this, you can answer an MCQ of 20 questions and you get a CPD certificate. So this is, of course, an app that you buy, and it is only open for medical professionals to buy. So I do hope you will consider supporting me by buying this app. So I'm now going to carry on with the talk. Let's look at assessment. Now, assessment is extremely complicated, and I'll show you there have been a lot of publications on assessment. Starting from 2007, Lambros, who I sort of consider, a guru for me, realized that there were all these things happening in the under eye area. And so he was looking at good skin quality, hyperpigmentation, groove definition, and orbital fat presence. So these are the four key things that you're always going to be looking at. You'll see that this is sort of a repeat mantra when you're looking at the under eye area. But his, scale was very minimalistic. It was 0 was poor, 1 was good, that kind of stuff. So it wasn't really, it was a very simple scale, looking at the correct things, but perhaps not offering more than that. Sadiq, around about the same time in 2007, came up with his tear trough rating scale, again looking at similar things, but giving them a more detailed score system. So he was looking at the depth of the tear trough, which is from the anterior lacrimal crest, how deep the tear trough goes in. And of course, he gave a point for now, for this, but this is a difficult scale to implement. This part, the depth of the tear trough, is a difficult scale to implement in clinic. Hyperpigmentation, prolapse of nasal fat pad, and loose skin based on the Glagau scale. So this was a good tear trough rating scale, although slightly complicated. In 2010, Herman came up with her classification, and I had the pleasure of meeting her. She's an amazing woman. And this is a really good classification that I like using. Now, I'll tell you the reason why I like using this. So type 1 tear trough is just a very shallow tear trough deformity. This is the most difficult tear trough to treat because it is the most challenging area of the tear trough to treat, both in terms of the visibility of the filler and the vascular anatomy. So a type 1 tear trough really requires the least volume of filler, but it requires very careful selection of the filler. The rheology of the filler is really important. You need a very soft filler with a very low G, with good spreadability. And you need to be an advanced injector to be injecting a type 1, because also, obviously, a type 1 hollow is a very subtle hollow, and the patient has high expectations. A type 2 tear trough is where the tear trough now extends into the palpebromalar groove, and often it will extend a little longer into the palpebromalar groove. This is a good tear trough to inject because you get a visible bang for your buck. The patient is happy. Often you can just do a 1-point injection, just a point over there, and you will see a significant improvement. And you can use a plethora of different kinds of products technically for this area. Depending on the overlying tissues, your rheology of the filler will change. And then you go into the type 3 tear trough. Now this type 3 tear trough was a deep hollow with the palpebromalar groove, with a deep groove going into the mid cheek area and the malar mound visible. Now this is a great tear trough to treat even for a novice, because even if you just inject indirectly into this mid-cheek groove, you inject a product on the cheek without the fear of going into the tear trough, you will get an improvement. So you leave your patient improved. So this is a good type of tear trough to start treating. Of course, it's also very important when you in your head start classifying this. And over the last 10 years, I've used the Herman classification continuously in my clinic, and I find it a very useful classification so that I'm aware of the quantity of filler that I need to be injecting. And I'm also able to talk to the patient about this and show them, how extensive their tear trough is. It extends beyond the actual tear trough groove into the palpebromalar groove, into the cheek, and therefore they need those areas corrected or addressed first. Then let's look at this new classification, which came out now 3 years ago by Turkman. And of course, it talks about a hill-valley type of classification. Now, of course, this is extremely simplistic, and you can see that this is a valley and this is a hill. But it's not a classification or an assessment tool that I would use, because it's not giving me any additional information scientifically. In 2018, Peng et al. Came out with the ABL categorization. And again, as you can see, this has a very simple thing. This is atrophy, bulging, and laxity. This is a good classification because you are beginning to see where the atrophy exists. However, it doesn't comment on the hyperpigmentation element at all, and therefore, with keeping that in mind, I'm more inclined to use the Hermand scale along with something that looks at the skin, which might be just the skin scale from the Sadiq's tear trough rating scale. What I do like, however, from this ABL categorization, which came out 2 years ago, is the tests that are used to assess the under eye area. And so they talk about the tilt test. Now, the tilt test means that you tilt the head, to see the extent of the eye bag. We've discussed this. The smile test. Now, this is a great test to do. I do this all the time, and it's really important because it tells you two things. They don't use it to tell you the two things. They use it basically primarily look at the fat bag. If you have a bag of fat, which when you smile disappears, it means that your deep cheek fat pad is pulled up, your orbicularis oculi muscle is taut enough when it's tightened to push back the fat pad, and therefore it simulates what sort of result you'll get with a filler. The other thing that you're looking at with a smile test is the amount of excess skin laxity that starts occurring. And it tells you whether you start needing to use combination treatments, whether you start needing to be using toxin along with filler to control that excess hyperdynamic wrinkling of the skin that occurs, because often patients would like to see a smooth result, and we often need to combine these kind of treatments. Then we do the pull test. Now, what is the pull test? The pull test is pulling the eyelid down to see how loose the eyelid is. And the snap test is where you pull the skin and let it go, and you see the recoil should be within a couple of seconds. And if it's longer than that, it means that the skin elasticity has gone. And so the combination of a lot of excess eyelid skin on smile test, a lax eyelid on pulling, and a poor snap, to me, would tell me that initially they don't need fillers, that I would actually go for an energy-based device to try and tighten the skin, or a surgical procedure before injecting volume. The squint test, again, is to see what kind of dynamic change occurs to the muscle, the puckering, and if the nasojugal groove gets more prominent. And then the push test. The push test is really interesting. Again, I do this all the time. You push on the deep medial fat pad to see how it effaces the under eye area. The other important things to look at a positive vector and a negative vector in the eyelid. So a positive vector is where the eyeball is actually sitting behind the orbital rim. Now, this is really important because if there is a positive vector, these patients can just be injected in the Trough area and the tear trough area, and they don't need a mid-cheek injection. However, if they have a negative vector, which means that the eyeball is sitting in front of the infraorbital rim and the cheek, the maxilla, then these patients actually need to be initially treated indirectly. They need this area augmented first before the tear trough is augmented. So obviously, when you're assessing these patients, you want to assess them sitting up or in a semi-reclined position. You want them to assess in the frontal position. You want to look at the hollow in 3/4. As you can see, this is a type 1 tear trough, very thin skin with hyperpigmentation. And you also want to look at them in extreme profile. And this is really important to be able to decide, the older the patient gets, whether you are going to treat them with surgery or with fillers. So when you look at this lady in profile, this is her fat bulge. And if you look at the amount of fat bulge and look at the hollow, and then look at the cheek projection, to actually efface this tear trough, you would need to fill a whole lot of filler like this. So this is almost like a 9-month pregnant tum-tum. So, this kind of look is an abnormal look. So this lady, I said to her, well, you're not going to do well with fillers because you need too much filler to efface that bag. In addition, the bag is a loose bag. And so I would do surgery. But when you look at this gentleman, you can see there's a lot of atrophy of tissue, quite significant amount of subcutaneous loss. Of course, there is loss of the Trough, the medial Trough, the lateral Trough, and In fact, even the mid-cheek groove has become hollow. But there's a mild fat prolapse and thin skin. Now, these patients will do really well with dermal fillers, but they need progressive treatments because the skin is thin. So remember what I said, a really large bag, a moderate sized bag, and very thin skin are both your red lights. They should be flashing that these are the patients that will not do well with fillers because you have more visibility of the filler or you require more filler. Um, and the more filler you put in, the more prone they are to swelling. So, summary of the assessment, to try and address if an eyelid is boggy is a pressure test. So I press at the malar mound area to see if there's any pitting edema. If there's pitting edema, then I'm not going to inject fillers because it indicates lymphatic stasis. You do the snap test to check for skin laxity. You check the vectors, particularly in profile and 3/4. And then finally, you pull the skin, and the skin assessment test is to not only see how loose the skin is, but you pull the skin to look for any skin discoloration, because you need to discuss this with the patient before you inject the patient. Otherwise, they're going to be really upset, because if they've come to you for a treatment of their under eye dark circles, and their dark circle is a combination of pigment and volume loss, they're going to be hugely upset if you've only restored the volume, but you haven't even discussed the pigment or told them that there's a pigment issue there. Right, let's go to another quick little plug break. So I would like to request that you consider donating to Akshaya Patra. Akshaya Patra is a charity that I support through OFAA. So my profits, most of my profits from my educational activities from my cadaver labs go to feed 2 schools in Gujarat, in India. This is my son and my husband and I. We went, a few years ago when we adopted the school, and we feed 500 children every year so that they are able to come to school and get educated. So we're not only getting rid of hunger, but we're also educating these children. And Akshaya Patra is an amazing organization that I have as my chosen charity, and I'd be so grateful. We're so privileged. We're all sitting at home with plenty of food. I know we're in lockdown, and I know people are in financial mess, but you are privileged because you have a roof, you have food, and you're getting free education through me today. So, even £10 a year will feed one child for the entire year, because the government gives a subsidy, and they come and they get educated. So I'd be so grateful if y'all could dig deep and donate to Akshaya Patra. Carrying on with my lecture. So let's look at the anatomy. I've already covered the anatomy, but I want to talk to you primarily about the danger zones, okay? So for this, we're going to get Stanley, all right? So when you look at Stanley, what I've done is I've put in some blood vessels for you to see. So of course, this is the orbicularis oculi muscle, and you can see that from the infraorbital foramen, you have the infraorbital artery that actually there is a nasal branch. There is this nasal branch can anastomose with the dorsal nasal artery. It can anastomose with the supratrochlear artery and the angular artery, basically in this zone. There are multiple anastomoses. This trunk runs medially. And then from the infraorbital foramen, there's another trunk that runs inferiorly, and this is the vestibular branch. And then there is another branch that runs which laterally along the zygoma, and this is the zygomatic malar branch. Now, primarily from this infraorbital foramen, the nasal branch, the infraorbital artery, and the zygomatic branch of the infraorbital artery are at risk from your tear trough filler injections. In addition, the angular artery is at risk from your tear trough filler injections. And there is also the zygomatico-facial artery, which when you do your lateral SUF correction, might create a vascular compromise. Now, when you actually look at the evidence, of blindness worldwide, it's a very low risk. The tear troughs are very low risk for blindness, but they do exist and there are cases. So you do need to consent your patient for this. Let's look at this vascular anatomy and where we understand the anatomy of the infraorbital artery. So you can see that the infraorbital comes out of the foramen and goes into these branches. You have the nasal branch, which anastomoses with the dorsal nasal artery and can also end in the supratrochlear artery or anastomose with the angular artery. And then you have the vestibular branch and you have the zygomatic branch. Now, the high risk areas, okay, are also the zygomatic-facial artery and the angular artery. But what's interesting is not just the distribution of these arteries, but also the depth of the distribution. Now, when you actually look at this image again, you'll see that the infraorbital rim is clear of these blood vessels. And therefore, technically, using a needle down on the periosteum is a safe zone to inject. And this is corroborated by a small study of 15 cadavers that was done by Tansatit. And what they looked at is they looked at the location and the variability of the arteries that are closest to the 3 key points we inject when we're injecting the tear trough. So they looked at TT1, which is the lateral area. As you can see, it's this area here. And what they found that in TT1 area, which is shown in green, in gray, 70% of the arteries were submuscular. So they were just below the orbicularis oculi. A very low percentage, 3%, were intramuscular, and about 23% were supramuscular. So basically, up above and below the muscle is primarily where these vessels were. And on the periosteum, it's just about 3%. Now, you have to remember that this was a very small study of 15 cadavers, and this was relevant to a Thai subgroup, Thai population. But, what it's showing is that predominantly the vessels lie above and below the muscle. So if you're on the periosteum, it is relatively safe. But you need to make sure you are on the periosteum and that you're not, dangling in free space when you're injecting here. Then we looked at the second point. Now, this is the biggest or the sweet spot of the tear trough. This point here, which exists at the mid-pupillary line, between the mid-pupillary and the medial limbal line. This sweet spot of injection, if you look at TT2, then 53% of the vessels were submuscular, 33% were supramuscular. Again, a very small percentage, 6 were supraperiosteal and intramuscular. So you can again see that, injecting pre-periosteally below the ORL is a relatively safe area to inject. However, remember that when you are using a needle, you're going through the skin and the muscle, which is where these vessels are. So the risk of bruising is higher. And then finally, we look at TT3, this point here, which is the true tear trough. And interestingly, in the true tear trough, 90% of the vessel was lying supramuscular. But what was also interesting is that if you were giving intradermal injections or just subdermal injections in that subcutaneous plane over the tear trough ligament, then this was a relatively safe zone to inject, because this 90%, with the angular artery being the closest, is actually in the nasojugal groove. So, summary, you are always going to be safer with a cannula when you're injecting the true tear trough. And the cannula is minimum gauge, 25 gauge. You don't want to go lower than that. So 27 and 30 G cannulas are needles. But it's also equally important to understand that when you are using a cannula, you have to be confident that you are pre-periosteal. The pre-periosteal plane with a cannula, particularly in the palpebromalar groove, can be a little challenging or a little sore for the patient when you're injecting. And the cannula tends to want to go in a subcutaneous plane very easily in the eyelid. And some of the major complications of swelling, tyndal, and migration, lumpiness of the filler that I see is actually from cannula placement. So you have to be a very good injector to be using a cannula. You can, it's a little more forgiving if you're using the needle on the bone, because you know your pre-periosteal. Of course, you again want to be, you're going to have that fallout of increased bruise risk. And certainly in this area, that is the area of the true tear trough, you don't want to be using a needle. As you can see, that there is a very high risk of a bad bruise, but also of an intravascular injury potentially because of the vessels being so close to that point. Now, let's look at the eyelid lymphatics. So this is now the next area that is important for the eyelid to discuss how to prevent swelling. So the eyelid lymphatics are extremely weak, they're extremely fragile, and they are predominantly in two sets. You have a inner corner, a medial eyelid lymphatic, and a lateral eyelid lymphatic. Now, this lateral eyelid lymphatic meets the medial eyelid lymphatic in this watershed area, which is this watershed area here. And this is an area where these eyelid lymphatics can be compromised, and repeated filler injections, large volume filler injections, large particle size filler injections, or hydrophilic fillers that absorb a lot of water and attract a lot of water are diabolical in this area, because you may not swell immediately, or you may have early swelling, but you will have delayed swelling. And a lot of patients that I see in my practice who come to me from elsewhere present with delayed swelling. So of course, when you look at this image from Jerome and Lamb's book, there is a whole superficial segment, the lymph capillaries, which actually then go into a deeper bit. And the way they do this is they do this in the Trough area. And if we were to look at how this pans out, you can see that the malar septum is an impermeable membrane that goes from the orbital septum along the orbital rim, and it reaches the skin. Now, this malar septum goes through the Trough, and it divides the Trough into a superficial portion and a deep portion, okay? And it's this superficial portion, this area here, this area, the central area here, where there is a confluence of the medial lymphatics and the lateral lymphatics, which is weak. These capillaries are weak. And for those of you who inject Profhilo, if you've misjudged the Profhilo point, one of the bioaesthetic points of the Profhilo, and you go a little higher and you just go into this area here, you can have some persistent swelling for weeks after Profhilo from this. So we really want to avoid superficial injections in this part of the eyelid. Okay, so this is where the impermeable malar septum exists, and anything that is injected superficially will start attracting fluid and will worsen a festoon and a malar mound. So that is the anatomical basis for this two complications we see. What are the other complications you see? Visibility of filler. This is because you've injected it in the wrong plane, the wrong depth, or you don't have adequate covering of tissue on top of it, like very thin skin. Tyndal is from using a particulate material that's put in a large clump, again, under very thin skin. So, the two factors that don't bode well for tear trough fillers is very thin skin and a very large eye bag. These are the two factors that you have to be careful about. The other two factors that you have to be extremely careful about is laxity of skin, lymphatic stasis, or a predisposition to collecting fluid, because this is an absolute no-no for injecting the tear trough. And the best way is asking a history, hereditary history. Smokers are more predisposed to this, and by actually checking if the tissues are boggy and loose, and you would be better off tightening the skin using an energy-based device before you inject filler. Make sure that the tissue envelope is taut. And then the fourth factor that doesn't bode well is obviously hyperpigmentation, because this affects your result. And when you actually restore the volume, you've only moved that pigment out and made it a little more visible. And so this is where the patients can be extremely unhappy. So let's have a look at where we are. I'm going to once again remind you, please, about my OFA app, which has got cadaver anatomy, live injections, and management of complications, common complications with hyaluronidase. So it's all done on cadaver labs. You don't need VR goggles. It's a much better experience if you can buy VR goggles, and you can buy a cheap VR goggle for 20 pounds or 10 pounds and put in your phone. It's a mobile app. So again, I'm going to show you what it looks like. You can download it on your phone and it will stay with you wherever you are. So this is my phone, and you can see the OFA app there. All you do is, this is something you carry with you, and it's visible over there, and you can go to seeing the videos. So this is for 250 pounds, and you can buy it on ofa.app. And then I'm going to end my first YouTube webinar on tear troughs with a great big thank you, and particularly a great big thank you to everybody in the industry who supported me by sending out emails to a large group of UK practitioners so that you could attend this webinar. And I would like to say grateful thanks to Church Pharmacy for their support and their continued support over these last 4 years. I'd like to thank SafeFace. I'd like to thank Sinclair Pharma for sending these mailers out, and also Bottle Science, that is SkinAid, and Fusion GT for sending out these invites. And if I've forgotten anybody else, my apologies. Yes, Academia, who sells, they sell anatomy books. So I'd like to thank them for their support. And the chat room is open. Send me your questions so that I can answer them. Bye.